Hello everyone, welcome back to my YouTube channel. Remember, this is the only channel that provides you with knowledge and insight about palliative care. Please don't hesitate to like, share, subscribe to my channel, and also tell a friend to tell a friend, because the ultimate goal here is to share knowledge and make people aware that regardless of their diagnosis and their prognosis, there is always something that can be done. So in this video, I will talk about care that is given at end of life. I know some of us, if not all, have been met by a situation whereby we are caring for somebody who is approaching their end of life or with a progressed illness. This video will shed light on what should be prioritized and what should be done to ensure the quality of life of that patient. I would start by defining what end of life care is. And end of life care is the care given to an individual or a patient who is approaching end of life or with a progressed terminal illness. This end of life does not only include the period that the patient is sick, but also covers the period of that imminent death. I know there are a lot of questions, even amongst healthcare workers, of when we should know a patient is approaching end of life, and there are the obvious signs that the patient will exhibit that will help us predict that this patient is progressing to the end of life. For example, a patient will have his or her breathing pattern changed, and this change in breathing pattern may be characterized by periods of apnea or noisy breathing. And this noisy breathing is because sometimes when a patient is approaching death, the swallowing reflex may be altered, therefore leading to accumulation of respiratory secretions in the airway. And as the patient tries to force air through the narrowed airway by secretions, a characteristic sound is produced, and this sound we term is as death rattle. The other characteristic that we may find in a patient who is approaching end of life is basically decreasing levels of consciousness. You may find that these patients will spend most of the time sleeping, and perhaps he or she was a patient who was previously not so much drowsy, but with time the drowsy has increased. That may be an indicator that that patient is approaching the end of life, in addition to his or her diagnosis. The other sign of end of life is the skin changes that comes with progressed terminal illnesses, and these changes may be basically discoloration of the skin or even extreme coldness of the skin, and this is due to reduced blood supply to the skin. The other characteristic is decreasing heart rate and weakening of the pulse. This may also be an indicator of end of life. The other characteristic is a patient with terminal illnesses at times may be subjected to multiple tests and examinations by the physicians or those who are primarily taking care of them in the hospital. And in this test, we might find that the patient lab tests are deteriorating with time. Remember, with interventions, worsening clinical findings or laboratory findings should improve, whether gradually or insidiously. So if we find that our patient's science laboratory works, for example, you may use parameters like urea and creatinines, the liver function test. A progressive worsening may be an indicator of end of life. So we also need to understand that things like hallucination, restlessness, and agitations may not be basically signs of end of life, but rather signs of poorly controlled symptoms. So let us not generalize those symptoms and regard to them as end of life symptoms, but rather effectively manage our symptoms, the symptoms the patient has presented, whether it's pain, whether it's nausea and vomiting, in order to achieve a better outcome in that patient. So when a patient is at end of life, there are various interventions that may be of beneficence to him or her, and also to the family, because in palliative care we extend our care even to the family, because once you have a patient with a terminal diagnosis, it will also affect you in one way or another, whether physically, psychologically, socially, or spiritually. So some of these interventions are tailored towards ensuring that the patient is comfortable and we are enhancing the quality of life. For example, some of these interventions may include providing respectful care. And respectful care means the care we are giving to this patient is equal to the care that is also being given to other patients who are well or who have illnesses that are curable. We should not separate, or we should not bring about disparities in the cares we are providing, but rather we should be more compassionate and even extend our empathy to this patient. The other intervention is that we should also always maintain privacy. You tend to find that most of these patients at end of life are even unconscious, or they have altered mental statuses because of the various symptomatologies they are undergoing. So we need to remember that privacy is a key element, and everybody needs privacy regardless of his or her situation. The patient has a right, if the patient is conscious, the patient has a right to determine who will take care of him and also who will come to see him or her. The other intervention is to always ensure that we maintain the patient's dignity and identity. Remember, as a person, there is always that respect we want, and that should not be altered. The respect should not be altered by the disease we are suffering from, and so it should be a priority to ensure that the care we are providing to this patient who are approaching death is dignified and also brings about the aspect of identity to that patient. Remember, sometimes patients who are approaching death might not be able to talk or to verbalize, and this may in turn lead to their relatives or those close to them unwilling to talk to them. One of the interventions that is very key in end of life is to encourage the relatives and families of these patients to talk to them. But you need to they need to understand that the patient might not be talking, but he or she may be hearing what they are saying. It is always good also to ensure that we give these relatives time. If the patient passes out, give them time to stay with to have a private time with that patient, in that state, in that dead state. So the other thing I will talk about is that at end of life, the patient may present with various signs and symptoms, but being that the patient, there are no curative intents to end the disease the patient is suffering from, doesn't mean that we should not manage the symptoms the patient is displaying or exhibiting. As our ultimate goal is to ensure that the patient is comfortable, and also the family. Remember, if the family tends to find their patient is suffering, they will also feel that suffering in their hearts. So there are some of the obvious signs that may be present at end of life, and one of them, as I had stated earlier, is something we call death rattle. And death rattle is basically a characteristic sound that is produced by patients who are approaching end of life. And what causes this is due to accumulation of respiratory excretions as a result of diminished swallowing reflex in that patient. And in turn, there will be a sound that will be produced when that patient is trying to pass air through the narrowed airway by those secretions. This is manageable even at home, because you tend to find that most of these patients are under home-based care, whereby positioning is one of the very important key elements in management of this. The patient should always be positioned either in the left lateral or the right lateral position. And to explain this simply means the patient head is side lying. Why is this so? This will help if at all the patient will have a coughing reflex. He or she will be able to cough out those secretions without them without aspirating them. The other management of that is doing suctioning. Suctioning is using a specific hospital tool called a suction, and this can also be available for those in home-based care. And what happens is that a suction tube is inserted in the patient airway, and through the negative pressure that is produced by the machine, it is able to suck those secretions into the machine, and the airway is cleared. The last management of it is use of medications that will dry up those secretions in the airway. The other sign of end of life is pain crisis. You tend to find that patients at end of life will have pain crisis. We need to assess these pains effectively, because pain can be due to multiple reasons. We not only suffer from physical pain, but also other types of pain, like for example psychological pain that comes as a result of the stress and depression that the patient has been subjected to by the disease. We also have social pain. Primarily this happens because probably the patient was previously working or engaging in his or her daily activities, but at a certain time this patient may not be able to continue with these activities, and that will in turn reflect as pain in him or herself. The other type of pain is the spiritual pain, and this is what the patient undergo in trying to establish what really caused this suffering or what really caused this illness to him or herself. So it is good to assess these pains effectively, because pain can be due to, and if you manage, if the pain is managed wrongly, then we'll have zero outcomes and the suffering will continue, of which our main aim in engaging these patients or in managing this patient is to ease the suffering and promote the quality of life and ensure a peaceful death. So we should not take it that because a patient is unconscious or because the patient is not talking, that patient is not in pain. And to talk more of this is to include even the pediatric population or the children. Some children may not be able to talk, but may display their signs in several manners. So we should not deny a patient pain medication, or we should not manage pain inadequately because the patient is not displaying the usual signs of pain. Sometimes the patient even may be used to so much pain that he may not characterize the pain as somebody else who have pain may do. So it's good to always manage the pain effectively and use the pain ladder, because physical pain is managed using different drugs according to the level of the pain the patient is suffering from. The other symptom or sign that may be present and distressing at end of life may be agitation, and this is a situation whereby a patient is not calm, and so this patient may benefit from a drug like haloperidol, that will induce some level of sleep to that patient and eventually calming the patient down. The last distressing sign is the terminal restlessness. This is a situation whereby the patient looks disturbed or is even anxious because he or she may feel or may find that death is approaching. Management of this is mainly pharmacological, whereby we apply anxiolytic drugs and also pain-killing medication like morphine. An anxiolytic drug is example of an anxiolytic drug is midazolam or benzodiazepam like benzodiazepine like diazepam, and this will eventually help cool the patient, induce some level of sleep in the patient, and ultimately help that patient relax and calm down. So despite management of these distressing symptoms, sometimes there is always dilemma about giving fluids and feeding at end of life, and I will expound more of this. I will start with fluids. You tend to find that most of these patients at end of life, they have multiple organ failures, and due to this, the patient will present even with edema in various parts, in the skin, or even in the lungs. So basically, fluids at end of life are not very essential, because on the other hand, dehydration at end of life is beneficial rather than harmful. And how is dehydration beneficial? A patient at end of life who is dehydrated will have less respiratory secretions. And if this patient has less respiratory secretion, his airway will be patterned, and he will have an easy time breathing. The other significance of dehydration at end of life is because it brings about the aspect of reduction of gastric secretions. Remember, these gastric secretions may lead to patient developing ascites. Ascites is basically accumulation of fluid in the abdominal cavity. So if a patient is not well hydrated at end of life, that will be beneficial to him or her, because the risk of developing ascites will be low. The last benefit of dehydration at end of life is because dehydration at end of life has a degree of analgesic effect, and this is because a patient who dehydrated patient will produce endogenous endorphins. Remember, these endogenous endorphins will help reduce the pain level of that patient. And also, dehydration lowers the level of consciousness of a patient, and if the patient level of consciousness is lowered, there will be less suffering, as he or she will not even sense the pain. So when it comes to feeding, you tend to find that most patients at end of life will not require a lot of feeding, because of the usual fact that their basal metabolic rate is low, and basal metabolic rate is the minimum amount of energy that we require to perform our body functions, like opening eyes, opening our mouths, moving our hands, etc. Remember, if a patient is not feeding at end of life, there are some benefits that are associated with it. And also remember, the argument on this is that these patients, they have multiple organ failures as they approach death. So one of them is the usual one, that it reduces the abdominal secretions, thereby inhibiting a development of ascites. Ascites, as I have said earlier, is accumulation of fluids in the abdominal cavity. The other advantage of not feeding is that fasting leads to fat metabolism, and fat metabolism eventually leads to ketosis and acidosis, and ketosis have proved to reduce to help in reducing the level of consciousness of these patients, thereby reducing their suffering. Also, fasting or a patient not feeding may lead to the production of endogenous endorphins, and these endogenous endorphins, they overall have an analgesic effect. And analgesic effect here, I specifically mean a pain control effect. whereby the patient is not able to sense a lot of pain in his or her body. So it is of significance that we should not force these patients to eat, because we tend to find that as we continue forcing these patients to eat or to eat a lot, they will develop, the food will have negative effects to them. Like for instance, a patient will develop abdominal distension because, for example, the bowel functions are diminished, and so that patient either cannot digest food or is digesting the food poorly. And as we all know, if the patient have abdominal distension, the abdomen will compress the diaphragm, and finally that patient's breathing will be altered. So it is my urge that we manage patients at end of life effectively, and also management of end of life is based on a multidisciplinary approach. We may involve other multidisciplinary teams, like for example, psychologists, social workers, other medical disciplines like physicians, oncologists, laboratory technicians. All of them, they should be on board, because this is a patient who we are managing a different aspect of him or herself, and not only the physical aspects of him or herself. So thank you for watching this video. Please remember to subscribe to my channel, watch and like my videos, as more videos of similar contents are coming up. Thank you.